So when we talk about myeloma, we know that it's a very heterogeneous disease. Some patients have an excellent survival, maybe even cured, while another subset of patients has a very poor outcome and may die within 2 or 3 years. And we can define these high-risk patients by looking at the genome of the tumor, by looking at cytogenetic abnormalities. We can look at the gene expression profile in the tumor. We can look, by using an old-fashioned technique, plasma cell labeling index, to the proliferation rate of the tumor cells. And we can also look at LDH. As Francesca mentioned, we can look at circulating tumor cells or the presence of extramedullary disease, which all confer a very poor outcome. When we talk about cytogenetic abnormalities, deletion 17p, translocation 414, translocation 1416, amplification 1q, and deletion 1p impart a very poor prognosis in our patients. Especially patients with more than 1, for example 2 or 3 of these adverse lesions have even worse outcome, as has been shown by the UK myeloma group. So patients with 3 poor prognostic markers have an overall survival of only 10 months, which is of course dramatically worse than what we typically see in our patient group. We can combine cytogenetic abnormalities with the ISS staging system, and in this revised ISS staging system, you can see that patients with ISS3 plus high LDH or with an abnormal cytogenetic abnormality have also very poor outcome. Then, in Rotterdam, the gene expression profile of tumor cells has been used to define poor risk, and by using EMC92, we can also identify a subgroup of myeloma patients that do very poorly. These patients have a median overall survival when they have a positive EMC92 profile of only 2 years. So these patients were characterized by looking at the tumor, but we can also define high risk by looking at host factors, age, frailty, presence of renal failure, and maybe also very important is to see what happens during treatment, because patients that do not respond to treatment, are primary refractory, have very poor outcome. And the same is true for patients that have an early relapse after transplant. For example, here you can see in an analysis from Jimenez Cepeda and another analysis from the Mayo Clinics that patients with a relapse within 12 months after transplant or within 2 years after autologous transplant, that these patients die rather quickly as compared to patients with a later relapse. So we have different ways of looking to high risk in multiple myeloma. We can look at tumor-related factors, host factors, or dynamic factors such as response during treatment. So the next question is of how to treat these patients at high risk. Well, I think it's very important that we get a good tumor reduction after induction, a good tumor reduction after consolidation. Today we are looking at complete response, but tomorrow I think we should look at MRD negativity. And this has been clearly demonstrated by the Spanish group. This is the Spanish study for younger patients that get VRD induction, transplant, and then VRD consolidation. And Bruno Paiva looked at MRD in this study, and what he demonstrated at ASH is that patients at high risk but get MRD negative do equally well as standard risk patients getting MRD negative. So the upper 2 curves are for MRD negative patients irrespective of their cytogenetic risk. However, the below curve, the worst curve, is for high-risk patients that do not achieve MRD negativity. So this clearly shows the importance of getting a very deep response in patients with high-risk disease. And the same, in fact, is demonstrated by the French myeloma group, which showed in the IFM 2009 study that, again, when you achieve MRD negativity in high risk, you do quite well, whereas when you remain MRD positive, the orange curve, you have a very poor outcome. So MRD negativity is the way to go. But the next question, of course, is how to get MRD negativity in these high-risk patients. So which induction regimen do we give them, which consolidation regimen do we give them, and which maintenance do we have to think about? Well, as already alluded to by Dr. Francesca, is that bortezomib has the advantage that it partly overcomes the adverse effect of poor risk cytogenetic abnormalities in transplant-eligible patients and also in transplant-ineligible patients. And this is, for example, shown in the HOVON 65 study, in which it has been prospectively demonstrated that bortezomib during induction as well as during maintenance is able to almost completely abrogate the poor risk conferred by deletion 17p, as shown for progression-free survival, and on the right for overall survival. And Dr. Alessandra from the same group showed that also in elderly patients, non-transplant eligible patients, bortezomib also abrogates the poor risk conferred by cytogenetic abnormalities. But again, this is a retrospective analysis in which VMP was compared with RD, because at this moment we do not have prospective analysis to demonstrate the value of bortezomib in this setting. But importantly, bortezomib abrogates the poor risk conferred by cytogenetic abnormalities in transplant-ineligible patients when you look at progression-free survival and at overall survival. So the question is, then, in transplant candidates, which triplet are we going to use? It should be a bortezomib-based triplet, but are we going to use VTD or should we use VCD? Well, the French group looked at this question, and what they found was that VTD induction was more active in terms of inducing VGPR or better than VCD. Philippe did not report high risk or standard risk in his blood paper, so we do not have information on that at the moment. Another way of treating these patients is to use bortezomib in combination with Revlimid and dexamethasone. And Dr. Rossignol, the current chief of Dr. Blade, as he mentioned at EMN last week in Torino, is that RVD or VRD is also a very effective regimen because it induces 38% complete responses after induction, and you can also see that CR rate goes up after transplant, after consolidation, and at the same time toxicity is milder than VTD because there is much less neuropathy. Importantly, Dr. Rossignol also showed that the rate of CR is very high in high-risk cytogenetic abnormality positive patients. 46% of these patients achieve a CR after induction. But then bortezomib is the first generation PI, and now we also have a second generation PI, that is carfilzomib. And here you can also ask the same question, is KCD or KRD the better triplet? And what Dr. Francesca showed is that in high-risk patients, KRD was more effective because there is a higher rate of complete responders and also a higher rate of at least VGPR in the KRD arm as compared to the KCD arm after induction. So KRD is also here the winner. And also MRD negativity was much higher with the KRD triplet as compared to the KCD triplet after induction. Siri, quiet. So I think we can conclude from these slides that combination of a proteasome inhibitor plus an IMiD is the best combination, the best triplet for high-risk multiple myeloma patients. And indeed, laboratory studies have also shown synergy between an IMiD and a proteasome inhibitor. However, in the future, as we have heard before from other speakers, we will probably also add an antibody to an IMiD, PI, dexamethasone combination. And in fact, various studies are currently ongoing to evaluate such quadruplets. For example, the PERSEA study will soon start enrolling patients to test DARA-VRD in transplant-eligible patients. DARA-KRD is an interesting combination that has to be evaluated, and the Germans have enrolled, in fact, all the patients in the high-dose 6 trial, evaluating ELO-VRD or VRD in induction and consolidation. And also isatuximab is doing a study to see whether the addition of a CD38 antibody makes sense. So the next question is how to consolidate the response that we have achieved. Well, Dr. Cavo from Bologna showed in a retrospective analysis that patients with high-risk cytogenetic abnormalities, not in CR before the transplant, benefit from a double autologous stem cell transplantation, because you can see that the progression-free survival curve and also the overall survival curves are better in the double transplant group as compared to the single transplant group. But again, this is a retrospective analysis and we need prospective studies, but at the moment we have those studies. And I think also Professor Sonneveld this morning showed these curves from EMN02, because importantly, in centers in this study that had a double autologous stem cell transplantation policy, there was a randomization between VMP consolidation, one transplant consolidation, or two transplants consolidation. And in this study, it was shown that high-risk patients with deletion 17p, 414 translocation, and 1416 translocation, that double autologous stem cell transplantation, as can be seen here on the left, had a markedly better progression-free survival than when they received only one transplant. And in fact, the poor risk was completely abrogated by doing two transplantations as compared to one, because now the curve for progression-free survival is overlapping the curve of standard risk patients. And also overall survival was improved by giving these high-risk patients a double transplant, as can be seen on the left. Apart from double autologous stem cell transplantation, we can also think of consolidation with novel agents, for example with VRD, with VTD, or with KRD. And maybe these regimens have a different effect after autologous stem cell transplantation. Maybe they are more effective after transplant because of an altered microenvironment. And the rationale for this type of consolidation is that it leads to deeper responses, a higher frequency of MRD negativity, and hopefully, because we have still to learn about this, this will result in an overall survival benefit. Then the last part of my story will be about maintenance, because once we have achieved a CR and hopefully in the future MRD negativity, we have to think about how to maintain this. It's not only important to achieve a good response, to achieve MRD negativity, but we have to keep it like that for the rest of the patient's life. In the meta-analysis of lenalidomide, which was published by McCarthy in the JCO, it was shown that lenalidomide results in an overall survival benefit. However, overall survival benefit was not evident in patients with high risk, so with ISS3 disease, with high-risk cytogenetic abnormalities, or with renal failure. However, in the UK study, MYELOMA 11, it was shown that lenalidomide resulted in a PFS advantage in high risk on the right, as well as in standard risk patients on the left. But also, in this study, there was an overall survival benefit for patients with lenalidomide maintenance and high risk. And this can be seen here in the right part of this cartoon. But what you can also see is that the curves for standard risk are much more higher than the curves for patients with high risk multiple myeloma, which indicates that we still need a better type of maintenance therapy for patients with high-risk multiple myeloma. And at the moment, multiple studies are ongoing to evaluate the value of proteasome inhibitors, of PI plus lenalidomide, of monoclonal antibodies or monoclonal antibodies in combination with lenalidomide in these high-risk or in standard-risk patients. And the study with a checkpoint inhibitor with lenalidomide is currently on hold because of the safety signals from the pembrolizumab studies, as was mentioned by Dr. Lonial. So when we combine all these different concepts and treatment recommendations, we can now look at how the nearby future would look like, because now we have some interesting trial designs for high-risk multiple myeloma patients, and these trials are currently enrolling patients. And one of these trials is from Germany, and the PI of this study is Katja Weisel. And in this study, she is going to treat high-risk patients with isatuximab KRD, then either one transplant or double transplant, and then IKRD maintenance, followed by IKRD consolidation, followed by maintenance with an antibody, a proteasome inhibitor, and lenalidomide. And when patients are not transplant candidates on the right, you can give them IKRD, followed by IKR maintenance until progression. And also in the UK, a study is now enrolling patients when they have a high risk of early death, as defined by the SKY92 gene expression profiler, or by the presence of at least 2 genetic high-risk markers. And in this high-risk study, patients are being treated upfront with a induction therapy consisting of 5 drugs. So daratumumab, cyclophosphamide, an alkylator, Velcade, Revlimid, and dexamethasone. This is followed by a transplant, Dara-VRD consolidation, Dara-VR consolidation, and then Dara-Revlimid maintenance until progression. And Francesca already mentioned the high-risk plasma cell leukemia study in which we treat the patients with KRD in induction, consolidation, and KR maintenance. And for the transplant-eligible patients, we have either 2 autologous transplants or the auto-allo approach. So hopefully our patients will benefit from this type of approaches in the nearby future. And then, a little bit more far away maybe, is that we will be able to upgrade responses, that we will increase MRD negativity by incorporation of new drugs with really new mechanisms of action. And then I'm thinking of bispecific antibodies, of antibody-drug conjugates, and CAR T cells, as have been discussed by Dr. Einsele and Dr. Lonial. Thank you for your attention.